Everyone. Good morning, everyone. Welcome to our Global Virtual Dental Symposium in 2020 from LifeNet Health, together with all our speakers from all around the world. Today we are very proud that we can start our second Global Virtual Dental Symposium series. I'm very excited for the next 6 weeks. We are hosting this symposium series. Today, we are very proud to have one speakers talking about the advancing allograft solutions in their field. First, we have Dr. Gonzalo Blasi, and the second half an hour we have a speaker from Netherlands, Marguaritha Stuffken. Dr. Stuffken is from the Netherlands and Dr. Blasi from Spain. So before we start our symposium, our webinar, here are some house rules. Please ask as many questions as you want, whatever you want, what you always wanted to know about allografts and their use in the today discussed field. Please use for this our Q&A or the chat note. We will then transfer this Q&As to our speakers. If you are a Spanish-speaking attendee, please tune on your translation button. We have simultaneous translating today. And just for all of you, we have a very short 3-question survey after the evening today. But coming today, today's first speaker, we welcome Dr. Gonzalo Blasi from Spain, especially from Barcelona. He will talk today about a cellular dermal matrix as a substitute of autogenous tissue. Where are the limits? So most of you probably have seen a short introduction of Dr. Gonzalo Blasi. He has his doctorate degree in dental surgery at the University Internacional de Catalunya from Barcelona. He holds certificates in periodontics and in implants and master degree in oral biology, all from the University of Maryland, Baltimore. And he is a diplomat of the American Board of Periodontology. Dr. Blasi works as an associate professor at the University of Maryland and at the Universitat Internacional de Catalunya, and of course in his private practice in Barcelona, specializing in prosthodontics. And we are very proud that Gonzalo, you are here together with us, and you want to talk about your specialty. The stage is yours. Please share your screen, Gonzalo.
Yep. Can you see it?
Yes.
Perfect.
Yes.
All right. So thank you, Peter, for the kind introduction. I want to thank LifeNet Health for inviting me to this webinar series. So today we're going to talk about the acellular dermal matrix and what's the indication to use it for root coverage. So before we go over acellular dermal matrix, we have to think about the objectives of mucochangeable surgery. So it's mainly, the main objective is to achieve complete root coverage or as much root coverage as possible. But we have to take into account that that's not the only goal, because the gain in keratinized tissue and increase in gingival thickness is what's going to give us the long-term stability of the coronal position of the gingival margin. So if we'll take a look at some of the literature, there's this group of the University of Michigan that published this meta-analysis looking at long-term results of root coverage with different procedures. And they saw that one of the main parameters that indicate the stability of the gingival margin is keratinized tissue width gain after surgery. Not only that study, but there's plenty of others, just this one, for example, from the group of Pini Prato, looking at long-term, even 35 years follow-up, looking at the gaining width of keratinized tissue with free gingival graft. Look, they saw that by increasing the width of keratinized tissue, they saw long-term stability comparing to untreated sites. They also even saw some creeping attachment, so some migration, some coronal migration of the gingival margin. So this is keratinized tissue width, and looking at gingival thickness, it has been believed over the years that the initial thickness, or so the phenotype of the patient, has also a critical role in root coverage. So our group in Maryland, we published this meta-regression analysis looking at the influence of initial thickness on amount of root coverage. And we saw that initial flap thickness only has some effect when not using a graft. So when we add a graft, even it's an allograft or it's an autogenous graft, this thickness doesn't play that major of a role. But what does play a role, and an important role, is not the initial thickness, but the final thickness. So how much thickness we achieve after our procedure. And we can see here two studies looking at autogenous tissue and a cellular thermal matrix, and looking at the gingival thickness, and they saw that by increasing gingival thickness, there was a positive, significant positive correlation between thickness and defect coverage. And even at 24 months, the group of Munich, of Otto Zur and Hurseller, saw that that was an important parameter. They also compared autogenous tissue to enamel matrix derivatives plus coronally advanced flap. And they saw that at 24 months with coronal advanced flap and enamel matrix derivative, the mean root coverage was approximately 54%, so very little. Because they didn't change the phenotype of the patient by using enamel matrix derivatives. Here we can see a diagram of the evolution of root coverage with autogenous tissue. And we can see on the bottom right side that the mean root coverage is about 86%. So 100% is not always achieved. And we can see also an evolution over time because the surgeries and type of surgery has been perfection. So going back to clinical cases, we're going to review 4 cases. 1 of them with autogenous tissue and 3 of them with a cellular thermal matrix, in this case, the Oracell. So we're going to go over the first case. So this patient was undergoing orthodontic treatment and presented with multiple gingival recessions that range from 2 millimeters to 4 millimeters. And we're going to focus on the second sextant, so from upper canine to right canine to upper left canine. And we can see, especially on the canines, we have deep recessions. We can see that there's lack of keratinized tissue, and even we can see the initial thickness or the phenotype is thin, especially on upper right canine, because by retracting, we see blanching of the gingival margin. So that's an indication of a thin phenotype. So our goal here is going to perform root coverage, try to increase keratinized tissue width, and increase the thickness for that long-term stability that we were talking at the beginning. So in this situation, we decided to harvest the connective tissue graft. And so to treat all these recession defects, we needed to go to both sides of the palate. So we decided to perform a vista technique where we did an incision on the frenum, and we elevated the flap through that incision and through the gingival margins and partially elevated the papillus. This is the tunnel elevated already. We see that we've been minimally invasive. We don't see any tears, any dehiscences or fenestrations on the tissues. And that incision that we did on the vestibule led us to do the procedure much faster. And so we harvested bilaterally a subepithelial connective tissue graft with a single incision technique. And we introduced the grafts through that incision on the vestibule. These are the both grafts introduced in the on both sides from canine to canine, and then we currently advanced the flap with 6-0 polypropylene sutures, and we left some connective tissue graft exposed in the areas of the canine so that we're gonna have that revascularization of the graft exposed, and that way will increase the keratinized tissue width. And so this is the healing at 2 weeks, which looks uneventful. On the right side, we can see that the graft that's been exposed is been revascularizing. And on the left side, we can see that there's we achieved primary wound closure on the palate. And this is the final result. After orthodontic treatment, after 6 months of ortho treatment, we can see we achieved complete root coverage, good aesthetics. We augmented the keratinized tissue width and the thickness. So what are the complications on using, or the downsides of using a autogenous connective tissue graft? So we have the risk of having intraoperative bleeding, damaging the great palatine artery. There's a lengthy procedure because we have a second surgical site. And then most of the time, the postoperative pain of the patient relates to the palate. And also the palate has limited tissue. So sometimes we have to do it in 2 surgical procedures, or we don't have enough thickness. So that's one of the downsides. Let me show you one complication that I encountered while harvesting a connective tissue graft. Same procedure as I showed you before. We did a partial thickness to harvest a connective tissue graft. We leave enough thickness to try to avoid necrosis of the palate. And this is the graft, more than 15 millimeter long, good thickness. And this is the suturing with crisscross sutures. And this is the healing after 2 weeks. And we see that there's partial necrosis of the flap. And this patient suffered great pain during healing. And this is at 4 weeks to see that the tissue is granulating in. But it was not until the 6th week where we saw that the palate appeared clinically healed and the patient didn't have any pain. So looking at some of the studies in the literature, this is a study published in our school in the International University of Catalonia, where we looked at the palate and when we harvest a connective subepithelial connective tissue graft. And so we looked at postoperative pain after a connective tissue graft and early wound healing index. So from 1 to 3, the flap is completely closed, and 4 and 5, there's incomplete flap closure, meaning that there's necrosis. And we have this diagram here that indicates that when there's incomplete closure or partial necrosis, the postoperative pain can go up to 13 days. So this is a big downside, not only for the patient and patient management, but also if we need to do another procedure on this same patient, they're not going to allow us to go back and harvest connective tissue graft from the palate. So there are some alternatives to connective tissue graft, which have great benefits. So because we don't have a donor site, there's less post-op pain, and we reduce the surgical time. So overall, we reduce the morbidity of the patient. And one great benefit is that we have unlimited amount of tissue to use on the procedure. So looking at acellular dermal matrix, we see that there's also been an evolution of the amount of root coverage achieved. And if we look at on the right bottom right side, we see that the mean root coverage is about 79%. So it's not far from those 86% mean root coverage that we saw in the first diagram. And so we have different alternatives to autogenous tissue, allografts, xenografts. But if we look at the last systematic review on Journal of Periodontology, there's great evidence suggesting that acellular dermal matrix is the best substitute to autogenous tissue. So let's go and review some of the cases using allografts. In this case, all of the cases have been treated with Oracell. So first case, this patient presented with deep gingival recessions again from canine to canine on the upper maxilla. And especially the canines are deep recession with some cervical lesions. Looking at the lateral sides, here we can see, especially on the number 23 in Europe, is the upper left canine, deep gingival recession with very thin tissue, as we can see there's blanching when retracting. So we treat this case the same fashion as the case that I showed with the autogenous tissue. We did a vista technique, and we elevated the flap through that incision. And then what we do through that incision is we introduce a blade and do a partial thickness to be able to achieve some coronal migration and passivity of the flap. And this way we avoid introducing a sharp blade through the gingival margin. So we got the orocell, we divided in two pieces. In this case, we used the thickness of 125 and 170/175. It's a thick graft, but that's why we do that incision of the vestibule, so that we can introduce the graft through that incision. Because if you try to introduce this thick graft to the gingival margin, you can create some damage or some tearing of on that gingival margin. So we introduce the graft on both sides, and then we can only advance the flap, and we suture with 6-0 polypropylene sutures. And this is the healing at 2 weeks, completely uneventful. You can see there's barely any inflammation. We remove the sutures. This follow-up of 4 weeks. 12 weeks, we can see how we change that phenotype from thin to thick, which is going to give us that long-term stability. And this is the before and after at 18 months. So it's, I think, a very good result. The patient was very pleased because we not only cover the recessions, we increased the thickness, increased some keratinized tissue width on the canines, and we achieved great aesthetics. So let's go over case 3, which is a bit more complex than the case that I showed you before. This patient presented gingival recessions and all over her mouth, but especially on the maxilla from molar, second molar to second molar. She also presented with some, she was partially edentulous on the second premolars with some atrophy, bone atrophy. So there's a horizontal defects. And we can see here the lateral views of both sides. And we see deep recessions, especially again on the canine sides, but also on the central incisors and the molars. And one issue that we have on this case is that there's some anatomical limitations because there's some interproximal attachment loss that's going to limit the amount of coverage that we're going to achieve. So we did the same procedure, small incision on the vestibule that's going to help us, going to aid us to elevate everything without damaging the gingival margins. But in this case, we did it a little bit smaller because we did a full thickness flap and crestal incision on the edentulous sides. And we're going to introduce the graft through those areas. Here's the implants placed. You can see on the right, on the left side, that implant had some bone dehiscence on the coronal aspect, so we needed to do GBR, so guided bone regeneration. Here's the procedure, the flap elevation. Again, we see that with this aid in the incision on the vestibule, we were able to do very atraumatic elevation of the tunnel. We polished the composites, we reduced the root prominence on the incisors, because the more prominence probably is a negative predictive factor for root coverage. And we grabbed the orocell and we divided again in two pieces. We introduced it through that tunnel, covering all the recessions on the maxilla. And on that area, we created some space to graft the area with a bone graft, in this case FDBA, again orograft, and we use another layer of orocell on top on the occlusal aspect and covering all the occlusal and bone graft and the other layer of Oracel. And this is the coronally advanced, some simply interrupted sutures on the crestal areas. 2 weeks post-op, you can see with this type of material, the amount of inflammation is minimum. And this is the 12-month follow-up with the radiograph of the implants. You can see that we also performed some crestal sinus lift. And this is the initial and the 12-month post-operatively. And so I have about 2 minutes left to go over the last case. In this case, the patient presented with several issues that needed to be treated, but we're going to focus on the lower incisors. The patient had some composite veneers that wanted to be changed. And this is the, after removing the composite veneers, we can see that there's multiple recessions with very thin phenotype. But also we see that the vestibular depth is very shallow, and that's going to limit us on how much coronal advancement we're going to be able to achieve. On the image on your right, you can see the thin phenotype of the patient. So we changed the approach a little bit. Instead of doing the incision in the middle, we did it at the level of the laterals, because on the mandible, I think this approach is easier than just performing one single incision. We elevated the flap through the tunnel through those incisions, preserving the thickness of the tissue. Again, same fashion, we divided the Oracel in 2 pieces, and we can see in this specimen we have some melanin pigmentation, which is not going to have any effect on the final outcome. We introduced through that incision of the vestibule the graft, and because we have limited amount of coronal advancement that we can achieve, we performed these horizontal sutures on the deep recessions on the laterals, lateral incisors, so that way we don't have any of the material exposed, and we avoid any type of possible necrosis. And this is 2 weeks post-op. Looks great. We did some resorbable sutures on the vestibule so that we don't have to remove them, because sometimes it's painful for the patient. And this is the initial immediate post-op, 2 weeks and 6 months post-op with the final prosthesis, in this case, ceramic veneers. And the patient was very satisfied with the outcome. We can also see in this image how we changed the phenotype and also the gain on keratinized tissue that we achieved with this material. And so as conclusions for my presentation, right now, the best alternative in the market to connective tissue graft is obviously a steroid matrix. I think thickness gain is critical for achieving long-term stability and stability of the gingival margin over time. And then flap thickness, flap design has to be modified depending on what type of material we're going to use. And so with that, I want to thank you all for your attention, and if there are any questions, I'll be more than happy to answer them.
So thank you, Gonzalo. There are several questions coming in already. There's one question: which type of membrane you prefer in this case?
So for me, when I'm not using autogenous connective tissue graft, the best alternative is acellular dermal matrix. And among all the cellular dermal matrix, the one that I have achieved the best results is Oracel.
Okay. Then there's another question. Your Vista technique, what do you think is the pros and cons if you compare the vestibule incision technique, the Vista technique, with the approach of Dr. Allen's tunneling technique?
So I think the great advantages of this technique is that you can do basically everything through that incision on the vestibule. You can do a full thickness flap or try to do a full thickness flap through that incision. That's going to allow you to preserve the most thickness of the flap without damaging or tearing the gingival margin. You can use it to introduce the graft if it's very thick without tearing or elevating any papillas. And then you can also use it to do partial thickness flap with a sharp blade instead of introducing a blade through the gingival margin, which is also risky because you can have a fenestration of the soft tissue.
Yes, thank you. The thickness of the membranes is one question here. What is the best thickness of the membrane? In this case, on the orsal.
So I think what I've been using and what I've had the best results with is the thickness that's 125/175, which I think is good. I mean, we talked about how important it is achieving or increasing the thickness and changing the phenotype of the patient. And I think with this thickness is great so that we increase or change the phenotype better than other thicknesses. And by using these techniques, by using this VISTA technique, this allows us to be able to introduce this thick graft to that incision.
Okay, thank you. There's another question. What are your indications for an ADM versus CTG?
So I think it's especially great when you have a patient that's coming from another office and had a bad experience with a connective tissue graft. But I think one of the best indications is for multiple recession defects. As I showed you in the 4 cases were multiple recession defects, and you can do that treating all the recessions at the same time and also reducing the time of surgery so you're less invasive and the morbidity of the patient is going to be reduced significantly. So for multiple recession defects of the patients that have recessions all over the maxilla and the mandible, I think that's a great indication. And sometimes there's some limitation of thinking that we won't be able to cover the graft, the whole graft, by coronally advance the tunnel. But we saw that we can laterally close the recessions with simply interrupted sutures and be able to cover the whole graft.
Yes. Okay. I have 2 questions coming in Spanish. Now, my Spanish is not the best. ¿Qué acondicionamiento realiza sobre la raíz?
Okay. Should I answer in Spanish or English?
In English. We have we have our simultaneous translator.
Okay, so the question was if we condition the root surface with any chemotherapy. So what we normally use here is we do some root planning. As I showed you, one of the articles by Alfonso Gil showed that the root prominence is a negative predictive factor for the amount of root coverage that we're going to be able to achieve. So we root plan the surface, and after that we normally use EDTA for 2 minutes.
Okay, and the last question, we have a lot of questions coming in. If we have time and if we see that we have enough time after the second session, we can of course come back to these questions. But here's the last one, also in Spanish. Podemos hacer regeneración ósea membrana y matriz dérmica.
Yeah, so the question is if we are able to do guided bone regeneration with a cerebrodermal, and the answer is yes. And then, as I showed on one of the 3rd case, we have the dental sites and we perform a guided bone. We achieved that pretty using a cerebrodermal matrix as a membrane. So it is possible, and there are some other companies there are some other companies that actually sell these acerothermal matrix for the use of guided bone regeneration.
Okay, thank you. I'm so sorry that we have to stop now with this question, but I believe that Dr. Blasi will stay for the next session and maybe is eager to answer some question later on. Thank you again, Gonzalo, for this fantastic presentation. I don't want to miss to thank you also Dr. Ocampo from Colombia. She is today our translator into Spanish. Thank you, Dr. Ocampo. And with this, I'm switching to Dr. Marguaritha Stuffken from the Netherlands. Dr. Stuffken graduated in 2005 and with a DDS, and 2007 at the Academic Center of Dentistry in Amsterdam. And she completed her advanced program for international dentists in prosthodontics and the postgraduate program for periodontics in the New York University. Currently, she is working in her private practice or in a private practice, specializing in periodontology and implant dentistry in Amsterdam. And today, we have Dr. Stuffken here talking about the management of gingival recessions, factors affecting the outcome. Dr. Stuffken, the stage is yours.
Yes, I'm trying to share my screen. Let's see.
Yes.
Okay. Good evening, everybody. I would like to thank LifeNet Health for having me in this series of a webinar. With this presentation, I hope that I can give you some guidelines how to manage recessions and therefore the expectations of our patients. At all ages, our patients can have recessions. The number of recessions in each individual patient increase when they become older. And if untreated, it's most likely that a recession will increase during time, also when the oral hygiene is sufficient for our patients. I think that we should always clearly understand the reasons and the goal of the procedures we are doing. For me, there are 4 main reasons to treat a recession. First of all, if the root is exposed, where there is no enamel, patients can have sensitivity with cold and warm. This is a reason to intervene. The lack of enamel can also cause root lesions in the roots, which is also a reason to intervene. Some patients are ashamed of smiling, and they are asking because of aesthetics reasons to treat the recessions. The last indication is that it can be really difficult to keep the gingiva around a recession free of plaque, although the patient has a good oral hygiene. The gingiva is often inflamed and the recession will increase over time. It is important to understand the cause of the recession and to control this first. The cause, the etiology of the recession can be divided into 3 main categories. First of all, anatomic factors, iatrogenic trauma. That's this trauma that has been induced by our dental treatments, and patient-related factors. It's often a combination of these factors which will cause a soft tissue defects. I will explain each category separately. First of all, the anatomic factor. I rather speak about phenotype than biotype. Phenotype are all the characteristics of an individual caused by the genetics. If the gingiva is less than 1 millimeter thick, we consider it as a thin phenotype. You can see that by placing the probe into the sulcus. If you see the probe through the gingiva, we consider it a thin phenotype. When you don't see the probe to the gingiva, is a thick phenotype. So you see much more often a recession when the phenotype is thin. According to the studies of Lang and Liu, if the amount of keratinized tissue, another word for keratinized tissue is attached gingiva, it is less than 2 millimeter, the gingiva is much more often inflamed. It's with a combination of poor oral hygiene that recession can occur. And when we have a recession, there is a dehiscency of alveolar bone. If there is a bodily movement of the tooth will be outside the biologic envelope, which can cause a soft tissue defect. Based on the studies of Wenstrom, the thickness of the gingiva, so the phenotype, can influence this. When there is a thin phenotype, it causes more often recession, also often in combination with dental plaque. A high and tight frenulum can give traction to the gingival margin. This makes it harder to clean. However, I put a question mark in my slides because between studies there is no consensus if this really caused a soft tissue defect. The iatrogenic trauma. This is trauma as a consequence of our dental treatments. An example is an orthodontic band, a clasp of a rubber dam, or overhanging cervical restoration. The third factor are patient-related factors. Traumatic tooth brushing is one of them. Risk factors are too often, too long, too hard brushing, changing a toothbrush too soon, using a toothbrush which is too hard, or having a wrong technique of oral hygiene. These patients are usually really motivated, but they do something wrong. For example, in this case, you can see there is a little cleft at the canine due to the fact that the dental floss is used incorrect. And this is a little bit a controversial subject. There are studies that conclude that with a certain parafunctional activity, such as bruxism, will cause tension to the CEJ, which results in abfraction and a recession. In my opinion, the recession only will happen with a combination of factors, such as poor oral hygiene or a thin phenotype. However, I think that we always should the parafunctional activity into consideration. This is a study done here at the university in Amsterdam. Oral piercings are tremendously harmful for the soft tissue. Tongue piercings have a big chance of recession lingually of the lower front tooth. The longer somebody has a piercing and the less keratinized tissue is present, the higher the chance of a recession. Of course, piercings are also harmful for the clinical crowns. Another patient-related factor is periodontitis. This consists of bone loss and an inflamed gingiva. After successful periodontal treatment and an improved oral hygiene, the tissue will be healthy but in a reduced periodontium. This causes exposure of the root and the recession can be the outcome. There's usually a lack of papilla. This brings us with a Miller classification. I don't know who of you are familiar with this, but this classification gives an indication how predictable the treatment of the recession is in relation to the interdental bone and the amount of keratinized tissue. With Miller classification 1, there is no interdental bone loss, and there is still attached gingiva around the recession. It's possible to correct the recession totally. This is also possible with Miller classification 2. There's no interdental bone loss either, but there is no attached gingiva. With Miller classification 3, there's interdental bone loss. You can see that because of the black triangle, so there's loss of papilla. 50% of the recession can be corrected here. With the last classification, there is severe interdental bone loss and correction of the recession is not possible. In addition, I would like to mention another site-related factor that can predict the final outcome. Some studies have investigated the role of the size and shown that a less favorable treatment outcome will be there if the recession is more than 3 mm width and more than 5 mm depth. The treatment options. In general, there are 4 options that can be considered for treating the recessions. The first option is not really a treatment. It's actually waiting. It's a watchful waiting. You just follow the recession and intervene if the situation gets worse. However, we have seen in one of the first slides that there is a higher probability that the recession increases during time. If the recession increase, it's less predictable to treat. Orthodontic treatment is indicated when the apex is outside of the biologic envelope of the alveolar bone. A restoration can be done to treat a cavity or reduce the root sensitivity. The recession itself is not treated, so this can become worse. The last option is gingival surgery. Hereby you restore the soft tissue. I would like to explain this with some of my cases. This case, we did some watchful waiting. However, this patient complained that the gingival margin was often inflamed and he had difficulty to clean the area. Based on the amount of bone loss, so this is Miller classification 4, it's not possible to correct here the recession. I decided to remove the freedom attachments and therefore it should be more easy to clean the area. An incision is made at the CEJ and a free connective tissue graft is taken from the palate. It's sutured down and the flap is left open, so it will heal in secondary on tension. This is the final outcome. The patient can clean the area better and the situation will be more stable long term. This is the lip piercing of Anna. The lip piercing was removed and what was left over was a recession. This is Miller classification 2 with a deep recession. There's no interdental bone loss, so the recession will be able to get 100% covered. The phenotype is thin and there is no attached gingiva. Here a flap is elevated. A connective tissue is taken from the palate. The flap is sutured coronally. And this is the final outcome. You can see that the recession is 100% covered. This is Jennifer. You can see that the phenotype is really thin and there's no attached gingiva. She got orthodontic treatment and slowly a recession at number 31 starts. You can also see a little perforation in the gingiva distal of tooth number 31. When the orthodontic treatment is completed, you can see the tissue around number 31 is inflamed with no keratinized tissue and the recession is present. Also the perforation is still there. The goal here of the treatment was to correct the recession and improve the phenotype of the lower front tooth to a thicker one. A flap is elevated here. You can see the dehiscency and buccal bone. A connective tissue is taken from the palate and the flap is sutured coronally. This is the final outcome. You see the total covering of the recession and the fenestration and little fenestration, not the little fenestration, but the pinch in the tissue is covered and there's keratinized tissue with a thicker phenotype. Surgical factors. Also the surgical factors influence our outcome. The corrected microsurgical instruments are a must. You know, otherwise it's like eating soup with a knife. It depends on the surgical techniques which instruments are recommended. Because we are dealing with such fragile tissue, you should always treat a recession with a magnification. I use always a 4.5 magnification. It doesn't need more explanation that a flap always needs to have no tension, so to be free of tension. However, I want to stress this out because this is one of the key elements for a successful outcome of the treatments. I always use 6 and 7-0 resorbable monofilaments. After 11 to 14 days, it will lose 50% of its strength. According to the cadaver study of Homely Wang in 2018, a sling suture with a single interrupted, so the SET technique, gives the best stability comparing with a single interrupted and a single suture alone. There are different studies that give a correlation between the thickness of the flap and the outcome of the covering of the recession. In this study, recessions of meter classification 1 and 2 were treated without any graft material. It shows that with a flap of 0.8 millimeter or more, there's 100% covering of the recession. The last surgical factor I would like to stress out is the position of the flap. This study shows that the position of the flap right after the surgery is really important. If the flap is placed 2 millimeter coronal of the CEJ, the covering will be 100%. So that means that we have to overcompensate and place the flap always more coronally. This is Jacob. He has brushed too hard. This is first at rest, and he changed his way of brushing before treating the recession. The tunneling technique is here used. A connective tissue graft is placed into the tunnel, and the flap is placed coronally. Some extra sutures are made with composite restoration for better fixation. This is the final outcome. You see 100% covering of the recession. Usually the tissue around the recession is non-keratinized. For the stability long term, it's important that the gingiva margin will be attached. Therefore, we take connective tissue from the pellets. This is a piece of connective tissue. It always should be 6 millimeter wider than the recession, and in general, it should be 1 to 1.5 millimeter thick. The pain that the patient experiences after taking a connective tissue graft is directly related to the thickness of the flap and not to the size. This is one of the advantages of a connective tissue graft. You need a second surgical site, which includes more pain and more surgical treatments. Sometimes it's also difficult to get enough tissue when you have multiple recessions. An allograft is a good alternative. This is also what Dr. Blasi talked about. Studies have shown that it can be used safely and it has the same outcome with a connective tissue graft. It's, however, in my opinion, a little bit more technique sensitive and is less forgiving. Histologic, there is no keratinized tissue, but the tissue do change from a thin to a thick phenotype, which is of good quality and provide long-term stability. This patient has some aesthetic demands to correct the recessions. You can see the composite restorations at the roots. The composite restoration are removed because there will no attachment to this, and a tunneling technique is used. An acellular dermal matrix is used and placed into the tunnel. This is right after suturing. Here you can see that all the recessions are covered, except I wasn't happy with the right canine and decided to do a touch-up there. This is the canine. You see here that it's really important that the flap is free of tension. I use here another allograft and suture it. And this is the final outcome. And this is the total case, the beginning and the final outcome, and the right and left side. This patient complaints about sensitivity with cold and warm. Note that there's a lack of enamel on the clinical crown. This cannot be covered with a soft tissue. The recessions are cleaned here mechanical. I used root planning. I always spend some time doing this. The goal is to decontaminate the root surface and expose the collagen fibers. There is no clear consensus what is the best way to clean the roots. Marguaritha in 2003 compared in a systematic review the chemical cleaning with citric acid, tetracycline, and ADTA. He concluded that out of the 34 articles, none of the chemicals provide a clinical significant benefits. A tunnel is made here. Also, an acellular dermal matrix is placed into the tunnel. This is sutured again. This is the final outcome. You can see that there is some missing enamel on the clinical crown. Some composite restorations are made here. And this is the final result. This is the beginning and this is the final result. I would like to conclude with the words that without recession, there is no growth. In order to manage this correctly, we should always first do a step back and make a good clinical judgment of the situation and know the biology and our surgical techniques. Thank you. And I'm also welcome to ask questions.
So here I'm back. Let's see if the camera is working. Can you hear me?
Yeah, we hear you, but I can't see you.
Yes. You can't see me? So now. There are several questions coming in. At first, thank you, Marguaritha, for the fantastic presentation. I just come directly to the question. Here's a question. What is the aim of free tension closure?
Now, the flap needs to be free of tension. Otherwise, the flap will pull back and you will get a recession right away. So it's always important that it's free of tension, the plaque. Otherwise, you get right away a recession back. Yeah,
thank you. What root coverage technique did you see in the patients treated with orthodontics?
With orthodontic, I used their unconnective tissue graft. And the reason I prefer in the lower frontus to use unconnective tissue graft, I prefer an allograft in general because that's much more comfortable for the patients to not get something from the palate. But what I said already as well, that it's a little bit more technique sensitive. And in my opinion, you really should cover an allograft 100%. With the connective tissue graft, you have a little bit more margin that if it is 1 or 2 millimeter exposed, it will integrate as well, and it will cover the recession. And also when there is like one recession or two, but where you get multiple recessions, it's preferable to take an allograft.
One question. The first case of recession, why did you use a free connective tissue graft with frenectomy? Why didn't you just cut the frenum and follow the case?
Because there is a higher chance that the frenum attachment will come back. So when you really place like a tissue there, it's you really not only decut the frenum, but you give really something for long-term stability and make the tissue thick there.
Okay, Thank you. Another question. You mentioned that the ADM is more technique sensitive than CTG. What do you think is the difference in the sensitivity of ADM versus CTG technique?
Yeah, what I said already, that you really need to cover it 100%, and within a connective tissue graft, you can expose it like 1 to a few millimeters. I mean, it's preferable to cover it all the way, but it's a little bit less technique sensitive, that you don't have to cover it 100%.
Okay, thank you. Here's another Spanish question. Clarissa, can you muy amable por la información presentada muy completa y excelente? ¿Nos puede informar el pronóstico de estabilidad de logros y los factores desencadenantes serán controlados? I'm sorry.
I hear some compliments, but the rest I don't get.
Oh, that's right, Dr. Marguaritha. You do understand some Spanish, correct?
Okay.
Okay. So the question was, ¿no puedes informar el pronóstico de estabilidad de logros si los factores desencadenantes se han controlado? Can you inform us of the achievement of stability forecast and if the triggers have been controlled?
Sorry, can you repeat the question?
Can you inform us of the achievement of stability forecast and if the triggers have been controlled?
The forecast?
There's not forecast.
I don't understand the question. The forecast?
Oh, sorry.
Go ahead, David.
Informar el pronóstico de estabilidad de logros si los factores descendantes sean controlados. So can you tell us what the outcomes would be?
If
the factors,
yes, yeah. Dr. Blasi.
It says that you can inform them of the stability and prognosis of the achievements if the etiologic factors have been controlled, or so if you have controlled the etiologic factors, what do you think is the prognosis and stability of what has been achieved?
I mean, what I said a little bit at the end. You know, when you see a case, just do first a step back and indeed, like, look at the reasons for the recessions. So indeed, anatomic factors. Sometimes you can't control them all when the phenotype is really thin, when there's no keratinized tissue. Sometimes then, you know, it can be maybe a little bit harder, but also you have to control the oral hygiene. I think that is crucial. And sometimes, you know, if you see, for example, you have interdental bone loss, of some factors you can't control, but then you also know that the outcome will be maybe less than 100%. But then you can tell that your patient and you know what to expect. But you know, you try to do your best to control all the factors as much as possible, and from that point of view, you can better predict the final outcome. And the more the control, the more you have in your own hands, the better will be the end result. I hope that it's a little bit answering the question. I don't hear Peter. Yeah.
There's another question. Sorry. Do you use also the matrix in cases with no KT tissue, or just in cases with a good amount of KT tissue and in phenotypes?
No, I definitely use it as well if there is no keratinized tissue.
Okay.
It really gives like histologic. You don't gain keratinized tissue, but it do change in a really thick phenotype.
Yeah, yeah. Thank you. Thank you very much. Another question for Dr. Stuffken or Dr. Blasi. I have another for Dr. Blasi. Your Vista technique is working also in case of bone loss.
So if we looked at patients that have interproximal attachment loss, and so we classify them as mere class 3 or Cairo RT2, the amount of the coverage that we'll be able to achieve is not going to depend on the type of technique that we're going to use, but on the anatomical limitations that we have. So that attachment, interproximal attachment loss, is going to reduce significantly the amount of root coverage that we'll be able to achieve.
Okay, thank you. And another question: in case of combined bone resorption and recessions, how would you manage this?
Combined, so I would manage it with the same approach, but letting know the patient that complete root coverage is not going to be feasible.
Yeah.
So
yeah.
with this biomaterial, I've been always using the same approach, and I think I've been having successful or quite successful results. So I keep using it no matter the anatomical limitations, because I know that it's not going to depend on my technique or the biomaterial, but it's going to the success is going to depend on what are the anatomical limitations that we see at the beginning.
Okay, fantastic. Can you see this question from one of the participants, Podemos hoy en día reemplazar? Because as you could figure out that my Spanish translation is not the best.
Yeah, it says.
Peter, I can do that if you want.
Yes, please, David. David, so, yeah.
Oh, sorry. I think Dr. Blasi had already started, but it was. I'll read the question in Spanish. Podemos hoy en día reemplazar el autoinjerto por alloinjerto para recesiones múltiples. Today, can we replace autograft by allograft for multiple recessions?
So I mean, there's no question that autogenous tissue is the gold standard still. It's the tissue, the graft that you're going to be able to achieve the greater amount of root coverage, the greater amount of keratinized tissue width, and the greater increase in thickness. But if we're treating multiple recession defects and we want to be less invasive and be able to treat multiple recessions at the same time, I think allografts can substitute autogenous tissue, but just letting know the patient that the result may vary or may be less effective than autogenous tissue.
Okay, thank you for this. So, if there is no, this question goes to Dr. Stuffken, did you experience some creeping attachment in the cases you had used the matrix you used? Dr. Stuffken.
Yeah, but in general, yeah, not to be fond of myself, but when I'm using the allografts, I usually have covers like 100%. And what I showed, like in the 1K9, I could wait for creeping attachments. That's definitely true. But this patient has high aesthetic standards. And I thought, you know, I can, with a little surgery, I can do a touch-up. So in general, if I predict it can be 100%, I have good results. And yeah, with the cane, I could have waited for creeping attachment, but with a touch-up, I got it right away, and it was for sure that I will get it.
Yeah, thank you. So thank you all the participants, all the listeners, the speakers. Thank you very much for this fantastic first round for our fall Global Virtual Dental Symposium. I highly encourage you next week to dial in again. We will have next week also two fantastic speakers. You saw it already a little bit. There is Dr. Glaser from Vienna. He's talking about alveolar ridgeplasty with allograft bone material through stem cell hosting. And we have Dr. Rawat Samarani from Beirut in Lebanon, particulate allograft in lateral and vertical ridge augmentation, a 10-year experience presentation. So thank you very much, all of you. Thank you, Dr. Blasi. Thank you, Dr. Stuffken. And thank you, Dr. Ocampo, for the translation, of course. I hope you will all stay very healthy, safely, stay out of risky zones. I wish you all, and we as LifeNet Health, we wish you all a fantastic week, a good day, everyone on the more west side of this world, and nice evening, good night to I think we had already someone from the Middle East, from Israel. We have people from Beirut, from Greece here. So good night and good morning to the others.
And don't forget to do the survey.
And don't forget to do the survey, please. Only 2 questions, so we can go better, or we can even include your topics, whatever was always interested in for you during the next sessions. Thank you very much.
Thank you.
Thank you all.
Thank you.
Thank you all.
Thank you.